In Module 4, we will review the clinical features of BPD. The learning goals of this module include knowing the common clinical features of BPD, recognizing different clinical phenotypes of BPD, and learning the pulmonary mechanics of infants with BPD. To qualify for the diagnosis of BPD, all infants will have some degree of chronic respiratory insufficiency requiring respiratory support and oxygen supplementation of prolonged duration beyond 28 days or 36 weeks postmenstrual age. However, their clinical course may vary significantly. Each column in this slide describes a potential course of clinical progression from birth till established BPD. Some infants may start off with mild RDS, requiring little or no respiratory support, but develop progressive deterioration of lung function over time. Nonetheless, given appropriate support, most infants in this group will be able to wean off support, and their BPD is usually considered mild. The majority of extremely preterm infants will start off with pretty severe RDS that most will need to be intubated and be on moderate to high level of ventilator support. Most of these babies will need ventilator support for some time, but can be weaned slowly. However, some babies can wean quickly to non-invasive support, but then needed to be reintubated or escalate on the level of non-invasive support over time. The respiratory outcome in this group of baby can vary greatly, that some can be weaned off support over time, and some get progressively worse and develop further complications such as BPD-associated pulmonary hypertension. The third group of infants is the least common but still can be seen in every NICU that takes care of extremely premature infants. They present with severe RDS requiring very high ventilator support from birth and go on with severe and chronic respiratory failure, unable to wean from the ventilator or high-level non-invasive support. The lung disease is extremely severe in these infants, and their courses are often complicated by pulmonary hypertension or other severe complications of prematurity. In recent years, we noticed that not all babies with the diagnosis of BPD are the same. Although all of them have some degrees of lung disease, we have observed that the key clinical features of these infants with BPD can be drastically different. According to the different key clinical features, we can summarize them into three major clinical phenotypes of BPD. That is severe lung parenchymal disease, lung vascular disease, and airway disease. However, these clinical phenotypes overlap with each other, and a very small group of infants have very severe lung parenchymal, vascular, and airway disease. In the next three slides, we will briefly discuss the clinical features of each phenotype. Infants with severe lung parenchymal disease, as a leading feature of BPD, often presents with severe respiratory failure, requiring high level of respiratory support. However, they often have no or very mild pulmonary hypertension or airway disease. In these infants, the intermittent hypoxia episodes or the BPD spells are from poor ventilation and worsened ventilation perfusion mismatch. The lung disease in these infants can vary from homogeneous lung disease, shown on the chest X-ray on the left, with diffuse haziness and global alveolar simplification, to heterogeneous disease, shown on the CT scan on the right, with areas of hyperinflation, cystic changes, and areas of collapse and fibrosis. Another phenotype seen in infants with severe BPD is characterized by mild to moderate lung disease and severe or progressive pulmonary vascular disease. They may have severe pulmonary hypertension or progressive pulmonary vein stenosis with or without pulmonary hypertension. Clinically, these babies often have high oxygen dependency, and their BPD-like spells are usually pulmonary hypertension spells caused by pulmonary vascular constriction triggered by agitation or stooling, resulting in worsened pulmonary perfusion. Without proper care and attention, or when acutely ill from a comorbidity condition like a viral infection, these infants can progress to pulmonary hypertensive crisis with severe hypoxia and right ventricular failure. The patients in this chest X-ray did not show much lung disease on chest X-ray or CT of the lung, but presented with severe pulmonary hypertension and RV failure. The two autopsy pictures on the right was from another patient who died with a pulmonary hypertension crisis. You can see the severe smooth muscle proliferation of her pulmonary artery and severe hypertrophy of her right ventricle. Airway complications from intubation and mechanical ventilation, such as subglottic stenosis, has been well recognized. However, little attention has been paid to the role of airway anomalies, especially functional airway anomalies, in BPD until recent years. Severe airway structural or functional abnormalities contribute significantly to chronic respiratory failure in some BPD patients. The BPD spells in these patients can be caused by intermittent collapse of the airway from severe tracheobronchomalacia. Many patients with BPD has wheezing episodes due to increased small airway reactivity. However, chronic wheezing in some of these patients may be associated with airway obstruction due to malacia, and therefore may be unresponsive to bronchodilator therapy. The two pictures shown here are bronchoscopy image from one of our patients with severe BPD. The picture on the left shows subglottic band formation from a previous history of traumatic intubation. The picture on the right demonstrates severe narrowing of the right main bronchus. To provide appropriate respiratory care for infants with BPD, it is important to understand the pulmonary mechanics of these infants. As young infants born prematurely, the chest wall of these infants are very compliant, and the respiratory muscles are still not very strong. In addition, many of these infants have disordered respiratory control due to carotid body dysfunction. In rodent BPD models, perinatal hyperoxia causes impaired oxygen sensitivity, carotid body hypoplasia, and decreased total afferent neuron number. Normally, hypoxia induces increase in ventilation, and hyperoxia suppresses ventilation. Infants with BPD have abnormal respiratory response to both hyperoxia and hypoxia compared to premature infants that did not need mechanical ventilation or supplemental oxygen. All infants with BPD have some abnormality in pulmonary function, and we will discuss this in more detail in the next slide. Many methods have been used to evaluate pulmonary function in infants with established BPD. However, accurate measurements in a young, unstable infant can be difficult to obtain. In general, infants with established BPD have decreased compliance, increased resistance with decreased conductance, reduced FRC, and reduced force flows. Current data also suggests that these infants mainly have obstructive rather than restrictive disease, and small airways are the primary contributor to the obstruction. Many infants with severe BPD have heterogeneous lung disease with areas of hyperinflation or cystic changes and areas of collapse. Airway obstruction from either anatomical narrowing or functional collapse can result in significantly increased resistance in certain lung units. With similar compliance, these lung units will require much more time to inflate and deflate. That is, the time constants in these units is longer. In addition, loss of elasticity can also result in a longer time constant in certain areas. Therefore, in infants with this kind of heterogeneous lung disease, we can simplify the pulmonary mechanics into a two-compartment model with fast and slow lung units. We will discuss the utility of this two-compartment model further in Module 6. This concludes Module 4. Thank you for your attention.
We would like to acknowledge the American Academy of Pediatrics, the Organization of Neonatology Training Program Directors, Neo Reviews, and Abbott Nutrition for their support of this educational program. This concludes this module.